question, Connor.
Yes.
Um, why is that we lose internal rotation when we have posterior compression and the opposite?
You would lose internal rotation if you had anterior compression.
Sorry, yeah, exactly. So for me, it's like counterintuitive. Like if I'm compressed here, I would bring my arm in internal rotation, but I'm losing that. So
yeah, think about like do it right now. Just everyone put your arm out at 90 degrees like this, and then just get your measurement, right? And then jam your arm forward, push it forward, and then try it. That's why. Because you are compressing this part of your rib cage. You're probably engaging your pec to adduct your shoulder, and then you can't really get somewhere you're trying to go if you're already there. So if you're already compressed in your anterior rib cage, it's going to be hard for you to further compress or potentially decompress that area to access the range of motion that you're trying to get. So it's a result of the compression, the muscular orientation secondary to that compression, and just the position of the shoulder itself. So when you have that compression, the shoulder is usually pulled forward, and then you have this situation.
okay, thank you.
Mm-hmm.
Connor?
Yes.
Can we go the one slide? It's I asked about it on our review session, but it's I'm still confused about it. The slide where you showed the one guy who had like really retracted shoulder blades, and you said that he was he would be restricted in posterior compression, or sorry, he would be restricted in posterior expansion of his rib cage. And then you had the other slide of the girl, and then the next one, exactly. I'm still like, I can't wrap my mind around how she would be limited in anterior expansion. Like, to me, it's like, if I look at someone with a flat thoracic spine, to me, it looks like they're limited in posterior expansion because there's no curve there. So Can you just clear that up for me?
Yeah. And I think that's a good question. Other people probably have too. So normal breathing mechanics are these things we talked about right here. This is what you would expect to see in a human that didn't have compensations, but turns out everyone does. So this is what happens with people. So when you have a posterior compression, you're going to have the shoulder blade squeezed back and down. So when that happens, air is not going to want to go backwards. It's going to want to go forwards because those scaps are preventing that expansion from happening. The posterior mediastinum, which is a very large portion of our thorax, is not able to expand. So because of this compression in the back, where's air going to go? It's going to go forward. So they're going to initially be able to anteriorly expand. So for them, if you squeeze your shoulder back, internal rotation isn't that hard, but if you squeeze your shoulder back a lot, you could see how that would be limited in external rotation because you're limiting the ability to expand those tissues, eccentrically orient them, and also get air in your back. Now, the narrow ISA is being pulled forward with her scaps because of the anterior compression and her diaphragm being super, super descended, which is changing the pressure gradient in her thorax, which is compressing her obliques, which is compressing her ISA, and then everything is being pulled forward, so to speak. So her scaps are being included in this. So you see forward head posture a lot with narrows because they have all this stuff pulling them forward, and then the scaps come with it. So that opens up their scaps for air to get back there. It's a very similar thing to if you were to, let's tie it into this right here. The influence of pronation and supination in a reach. So if I pronate my forearm and reach, then I'm going to get external rotation of the scapula, which is going to push it back, which is going to make air go more forward. Whereas if I supinate my arm and turn my hand outside like that, then I'm going to get more internal rotation of the scap, which is going to pull the shoulder blade away from each other. And then you're going to get more posterior expansion.
Okay, I think I was trying to look at two things, and you were pointing to the scapulas. Like this one makes so much sense to me. Like I can totally understand why he would be like limited with anterior expansion. But this one, I think what you're saying is because she's going to be limited in anterior expansion. So the scapulas are being pulled forward, but they're like, when they're pulled forward, they wing out. Is that what you're saying? Okay.
Yes, that's very common. Like you see right here.
Yeah, but then also like, I mean, there's you can tell by the photo, there's clearly a lot going on with this person. But if I look at her from the side, like she just looks like her back's a wall, like a flat wall. So it's like, so if I was to see that again, I would think that she has a hard time expanding into the posterior side of her rib cage because of the fact that it's a flat wall. But are you now when you're looking at the scapulas and the spine, are you thinking two different things? Like I said, this image there's a lot more going on than just winging scaps. But were you showing this image just for the scapulas, or were you also thinking about the spine as well?
No, I think the spine is definitely a player in it. And I just got my mic from falling. So if you have a flat back, which when I was first learning this stuff too, I thought the same thing. You would think a wide would be able to expand posteriorly because they have that big degree of thoracic kyphosis, but not necessarily because of the orientation of the musculature and the scapula. So when you have a flat back, yeah, she's probably not maximizing air going backwards, but it's certainly way better than what's going forwards because she has a down pump handle. All those things I explained earlier are compressing the front side of her body. So air has to go somewhere. Literally, it has to go somewhere. So it's going backwards, but it's still probably not great. But it's a ton better than anything that could be going forwards right now because she has all of this compression going on the front side of her body. So it's relative, but because everything's being pulled forward, it allows for that relatively more.
Okay. And sorry, I'm just gonna ask one more question. I asked about in the Slack, I asked about the pooch belly because one of my clients that I just took on presented that. So I was like, okay, I assumed that when I checked her breathing, it was just going to be all into her, like the low abs, like the pooch, but it wasn't. So she has like a very distinct pooch belly, but when she breathes, it's a lot of like anterior, like kind of like the upper compartments. She's using her shoulders. So I was kind of like, what would you think about that? Because it looks like air is going somewhere, but then when you assess it, it's going somewhere else.
Yeah, I think I'm glad this is the assessments week because we've had a lot of these things where it's like, I see this and therefore what? But I think the visual stuff, I hardly ever go by. I go by objective measurements almost every single time. So what I would imagine in your scenario is that this person has compensated from their baseline pattern and they're kicking on their traps maybe to bring air and suck air in through their neck rather than expanding parts of their rib cage that are restricted. So you said this person was narrow, so they have that pooch belly. Maybe they've closed themselves off posteriorly, which we'll talk about next week. And now air is not going anywhere. So now they're trying to get air to come in by pulling up, which is something that you see quite often. So I would be curious what her assessment results in her thorax is, because then through these different assessments that we're going to talk about in a second, you'll just know where to plug and play. You'll know where the restriction is. And then that's going to give you the best possible way to address that situation.
Thank you.
Anything else? All right, let's get to it. All right. So like I said, at the end, we're going to be going through a big assessment together. And until then, we're going to be relatively stationary. So let's go ahead and make sure I'm recording here. Yes, I am. Okay. All right, week 4 into the first month. So today we're going to talk about what each of these tests is going to be basically assessing. What are we looking at and why does it matter? We're going to understand what constitutes a given biomechanical pattern result. So we should be able to know what to expect with the baseline presentation of someone who's wide, narrow, left AIC, things like that. And then know the general limitations for each respiratory bias in a primary compensation. Understand the importance of test and retest protocols. Massively important. That's pretty much what's going to give you all the information is the test and retest. So with that being said, let's talk a little bit about scope of practice before we get into it. If you're a strength coach or a personal trainer like myself, we are not physical therapists. So we cannot diagnose and treat. So we have to be very, very careful with this assessment. We can get into a lot of trouble if we choose the wrong words. So we can assess people with table tests, and we can help people understand what pattern they're in. But if we say you have scoliosis and here are exercises for your scoliosis, you're probably screwed. So I would say be very, very careful. Use the right words. And if you do that, you should be okay. And also make sure they're signing legal documents and all that good stuff, like they probably should be anyway. So with these assessments, they're active, a lot of them. One of them is passive if you're in person with someone, but clients will want to tense up. They still need to be relaxed. They're going to want to pass the test. And I don't know why, because they're usually having restrictions. So they try to like actually make themselves look better than they really are, which makes us see them in a different way than we probably should. So I like to tell everyone before I assess them, like the goal for you is not to pass the test. The goal for you is to actually just go through this and help me understand your body. So make sure that they're relaxed and they're not trying too hard. The first test we're going to talk about is an Ober's test. Now, because of COVID, I did not have anyone to do this on. And then when we filmed the assessments, we actually just didn't do this one. So our friend Neil here is going to help walk us through the Ober's test. So the goal with this is to assess someone's ability to go through pelvic, internal rotation, adduction, and extension. The very first step you should do is get them to chill, to relax, bring that knee up and back. And then you should have a straight line from the knee all the way to the hip, all the way to the shoulder. If they extend their back because they can't get hip extension, then the test is over, because you're now just going to try to get adduction and internal rotation without extension, and good luck. So there should be a perfectly straight line from the knee all the way to the shoulder and head. Now, what you want to do is make sure that tibia is in line and parallel with the floor. If it is pointing up or down excessively, the test is going to be altered. So what you want to make sure they do is just kind of shake that leg a little bit, make sure it's relaxed, and then just passively drop it. If they get stuck halfway to the table, they didn't pass the test. It should drop all the way to the table. All right, Neil, drop it. There we go. So that would be a pass test. Did you guys see how easy that dropped? If it was sticky, if it felt a little janky, then that's probably not a pass test. I would say it needs to feel pretty smooth, and it shouldn't be through any conscious input of them. They shouldn't be trying to help you get that leg down. So if their back arches, they're missing hip extension. If they're halfway to the table, they're missing IR and adduction. If they get it all the way to the table, you know that they can access these three things based on this test. But we also use other tests to cross-reference. Active knee to chest is one that I use with pretty much everyone. I think this is a fantastic test. It's assessing external rotation, abduction, and flexion. The key here is to make sure that that leg is staying flat on the ground, the passive leg, because that active leg is going through more counter nutation, where the down leg is going through more nutation, hip extension. If they lift up that leg like that, you know that they're cheating. You guys see that? That's what I always look out for. So that's why I like to do this with the feet up against a wall, because then they don't really have the opportunity to take pressure off the wall if they're driving their heel into it. That would be a cheat. There's some other things that can happen. You want to make sure that this comes perfectly straight back. So look at them from the side and also downstream. If they bring out that leg too far and they start to abduct it, you know that they're cheating on the assessment. So it's got to be a pretty straight line. If you see something like that, you see how that leg starts to turn out, that would be an indication that they're cheating and they're out of range of motion. Something like that. Another thing that can happen is their leg, that toe just starts to spray out because they're rolling. So if they're rolling on the table and their pelvis is moving, that's an indication they're also out of range of motion and they're just trying to cheat and pass the test. So if they get 60 to 100 degrees, they have a pelvic internal rotation bias, probably. They probably can't re-access counter nutation. If they get to 110 to 130 degrees, that's good. I'm really looking for 120, but at about 110, they're going to start to do that. And then if they get way beyond that, if they get 130 degrees, they're probably starting an anterior pelvic tilt on the table. So think of it like this. Think of it like you're sitting on a table and you can't really get, you see this quite a bit. They'll lay on the table and they can't get either hamstring flat on the ground. So what they're doing is they're basically starting an anterior pelvic tilt. So then they just flip this back because they're already starting in a degree of hip flexion. So they just get way more, not because they have it, but because of where they're starting. So that's something to look out for. The active straight leg raise is next. And some people will do this test. Like you guys look at FMS and things like that. They'll say, I want 90 degrees on a straight leg raise. Why? Because that's just stretching the crap out of your hamstring. We want 70 degrees. And we'll see why in just a second. But it's the same thing as the active straight leg raise. If they're lifting that other hamstring off of the ground, we have a problem because they're compensating. What this is assessing is femoral internal rotation, nutation, and then recounter nutation of the lumbar spine at varying degrees of this straight leg raise. If you see that, you know they're cheating. If that knee bends at all, you know that they're cheating because they've lost their femoral IR. If that hamstring comes up, you know they're cheating. Sometimes they'll kick it out to the side too. You see crazy stuff with these assessments. We tried to cover everything. That leg could also spray out to the side like that. They might lose it on the wall in an attempt to get that leg even higher, or they'll just bring it out to the side. And that's them trying to find internal rotation as well. So the test is going to be over when the knee bends, the other leg comes off the floor, or the pelvis rolls to one side. Now, this is testing femoral internal rotation because of the screw home mechanism. When we lock out and extend our knee, the femur goes into relative internal rotation and the tibia goes into relative external rotation. This is going to tighten the ligaments of the knee, like the ACL, the MCL, the PCL. You guys ever seen crazy ACL injuries? They're usually taking place when the knee is locked out to some extent because those ligaments are taut, some pressure comes in, it's over. And then oftentimes you see more than one ligament go. So that's just something, a little fun fact for you, but also understand that this screw home mechanism is extremely important. So that's why if the knee bends, we have an issue. In terms of results, so these are the varying degrees at which those things I mentioned happen. From 0 to 45 degrees. This is technically more of an external rotation bias because if you think about the Lindmark model, we haven't really entered the degree of hip flexion where we're going to be accessing internal rotation. So if someone has a 45 degree or less straight leg raise, you know that this crap in here is just really tight. You know that the deep hip external rotators, the gemelli, the piriformis, obturators, things like that, they are compressing this, which they could probably get to 40-ish degrees, but then after that, they need to nutate. They need to open this up and go into more IR. This needs to happen. But if these deep ER muscles are concentrically oriented and not allowing that to expand, then they're going to be stuck. So beyond that, from 45 to 70, you need to nutate and get into IR. But then after about 70 degrees, once you reach about 70 degrees, you actually need to counter nutate your lumbar spine. You need to do that. This needs to come back to allow for that final range of motion. So if I have someone who has a 110 degree straight leg raise, it's probably very similar to the hip flexion. That would be extreme. You would see an individual that is either rolling like this. They start on the table here, they roll and they kick that leg back, and or their hamstring is extremely lengthened and they just flop that thing up there and they just get it up there in half a second. That'd be an indication that person is really eccentric. You see that in narrows a lot. They'll just, and then they're like, I have a great straight leg raise, and you just have a long hamstring. So that's something to look out for. For the squat assessment, this is just a body weight squat. So The goal here is ass to grass, but it's so relative because people have different genetic backgrounds, different genetic morphology. Some people can't get ass to grass in a squat, but it should still be below parallel. So if you look at him right here, he's getting, I would call this a pretty full squat. He's getting his butt to basically the back of his ankle, which is pretty good. You can look at it from the back too to get sort of an idea of if they hip shift at all. And you can also look at it straight on from the front, making sure that everything is staying aligned. Now, some things you might see here is their legs could be too wide. If their feet are too wide, it's going to make it very easy for them. If they turn their toes out, it's going to be way easier for them. You also might see them do that. That's very common because that's just them trying to screw themselves out into ER to complete the squat instead of getting the relative motion at their pelvis. A wide, I'm wide, so he's narrow, I'm wide. That's my squat. It's not great because I'm nutated and very compressed. So if I went any lower than that, I just round my low back and I butt wink in an attempt to find that counter nutation. So what's up?
Can I ask a quick question about that?
For sure.
Okay. Can you just play your squat, like that last little bit where you butt winked really hard?
Mhm.
Right there. Okay. So couldn't you also say that if you had more dorsiflexion, that would allow you to stay taller through there? Or do you find that doesn't work?
I think that's true to an extent, but I don't want more dorsiflexion in this sense because then I would bypass the pelvic mechanics that would be necessary. You know what I'm saying? So like that's what people say, like, how do I get a deep squat? Punch that into YouTube. Here's an ankle dorsiflexion stretch.
Sure. Yeah.
You know what I mean? Yeah.
Mm-hmm. Okay. So you want the assessment to be here. So you're looking at the pelvis.
Yeah.
Okay. All right. Okay, cool. Thanks.
Of course. Something else you might see is they just might look like a bomb being dropped out of an airplane and just like they just literally fall to the bottom. So if they fall uncontrollably to the bottom, then you know that they're bypassing internal rotation. You see that with narrows, younger females a lot, they just drop because they don't have the internal rotation. So that's something to look out for too.
Connor, are we saying the first guy wasn't butt winking?
I would say no.
Okay.
I think that's not a huge issue because if that's like a day one assessment, I'm going to call that a pass because he can sit in there and he can be comfortable down there. You can tell.
Yeah, cool.
But I could see what you're saying for sure. Something I am looking at too. I don't put this on the slides because it's just this in of itself is the pelvis is what we're looking at here. But the way that he bends through his upper back, you'll notice how he has this kind of ridge right here. Pay attention to that when we talk about the toe touch. So if they get less than 60 degrees, which isn't very common, you know that they can't access IR or nutation. You know that they got a lot going on. From 60 to 100 degrees, they're going to nutate in IR, but they can't recounter nutate their sacrum and access those pelvic expansion mechanics. Beyond 100 degrees, they're going to be able to do that. Because remember, we only really have like 120-ish degrees of true hip flexion. So we can't really say it's 120 plus here. Now, this is another upright test we can use is the toe touch. So the goal is to have your fingers touch your toes. The goal is not to palm the floor because if you palm the floor, it's very similar to the straight leg raise. You know that you're just compressing the crap out of the front side of your thorax or using your hamstring length to allow yourself to palm the floor. Now, his looks pretty good. I have one of me later on in a picture, but I would say this is a pretty good looking toe touch. If they bend their knees excessively, you know that they're just cheating for obvious reasons. If they hunch, they're trying to seek a compression strategy in order to get the job done. You see this right here. That's using a rectus strategy. That's using their six pack in an attempt to compress and just pull themselves down. You can also see them do some funky stuff with their feet. They might spray their feet out too wide. They might rock excessively back on their heels or turn their feet out. Now, this is actually testing the full limb arc model as well of ER to IR to ER. So when we're at the top of the toe touch and we go down, we're going to be more biased towards counter nutation. As we get towards 90 degrees of hip flexion, we start to compress and go into nutation, very similarly to a deadlift. And then beyond that, we have to re-counter nutate the lumbar spine, and it has to come up like this, which allows us to drop deeper. And you get a little bit of that low back rounding, which is totally okay in the last part of a toe touch. So if their knees come forward, they don't have a posterior translation of their center of mass, or if they have this tent that I referred to as that rectus strategy, the test is over. Or if their knees bend, you see just anything that looks kind of funky. So if they get to their knees, then you know they can't nutate. They can't get into IR. If they get to mid shin, you know they can nutate, but they can't re-counter nutate. If they get all the way fingers to toes, you know that they can get, according to this test, ER to IR to ER, the full limb arc model. I had to include this slide because you see crazy weird things with the toe touch. So some things, here's me right here. You see I have this little tent. I have some expansion, eccentric orientation in my mid thorax. I have a flat upper and lower back. So that's telling you that this little tent is a representation of me using my rectus to pull me down there. If you see a totally flat back, then you know that they have probably very, very long hamstrings. If you see no posterior weight shift of the pelvis and they just palm the floor, you know they're leveraging a compression strategy and or the length of their hamstrings, and they're bypassing the pelvic mechanics. Instead of using relative motion, they're just dumping forward. So instead of going from here to here and then back here, they're just doing this. Okay, those were the lower body tests. Let's talk about the upper body tests. So shoulder, that's an interesting little screenshot there. Shoulder internal rotation is assessing anterior expansion. We kind of touched on these earlier within last week and what compression leads to what restrictions. This is how we now measure it. So what we do is we keep that posterior shoulder on the ground. So what I mean by that is right back in here, because if that comes forward, then you can easily cheat on this test. That's what I'm looking out for first and foremost. You can cue them to keep the other hand on that shoulder to help make sure they do that. Now, if you guys have ever taken a PRI course or anything like that, they like 7 or 90 degrees. They want you to be able to, there it is right there. They want 90 degrees, but I've found and I've learned that it's really not worth getting the extra 20 degrees, especially since this is an active test. Now you could do this in person. I don't show that because I know we have a lot of people that do online stuff here. So as it relates to this test, 70 degrees is perfectly acceptable and anything beyond that's great. But if you get 70, I'd check that as a win and move on. So this is testing for that anterior T5 to T7 expansion. Some other things you might see here is their back will arch in an attempt to get that shoulder down, or discomfort is felt. Now, something happened in this video that I wanted to show you guys. If you start too low like this might look okay to a lot of people, but that's too low and it's so easy to get that range of motion. So that's why I always cue be elbow directly in line with your shoulder. From there, it's really easy to go into external rotation because you're just starting in the same place. The goal here is 90 degrees. Anything less than that, then you know you have some degree of restriction at T5 to T7 posteriorly. So it looks like I'd say like, I remember doing this. I think I was at about 85. But it's my left side, so we know that I'm going to be relatively more limited there. The same stuff you're looking out for here, nothing crazy. That's another thing you'll see people do. They'll use their fingers as if that's giving them more range of motion, and they're just like trying to pass the test. So if they do this on IR, if they do this on ER, just make sure it's nice and straight. So less than 90 degrees, limited expansion in posterior T5 through 7. 90 degrees, you know they got it. Shoulder abduction is another one that we can use. And I really like this because you can just do all this at the same place. This is very simple and it's very quick once you get the groove of it. So the goal here is 30 degrees. And you want to make sure that that palm is staying nice and upright and it's not rolling down or up. So this is actually testing for both anterior and posterior T5 through 7 expansion. You know that this test is going to be over when you see that they either get some sort of like posterior shoulder pushing forward, you might see their back extend, or their palm or forearm rotates. So let's see if I can find one where I do that. They also might go too high or they might go too low. You rarely see that, but I wanted to include it anyway. That's what I'm talking about. If you see that. If you see their palm go down, it allows them to get more range of motion, but it's also a cheat. Something I also see quite a bit with this is nerve sensations. You'll hear people frequently say, especially like muscular wides, you'll hear them say, oh, I get like a little weird numbness going down the side of my arm or my bicep. And that is what I would call I would stop the test at that point. So this is, to wrap up my thought earlier, this is testing anterior and posterior expansion because if you have really tight pecs and a compressed anterior rib cage, you're not going to be able to drop that arm. If you have a very compressed posterior rib cage and you have concentrically oriented muscles around that region, like for example, some of your traps, some of your lower rhomboid fibers, if those are concentrically oriented, you're gonna have a really hard time dropping that arm any further. So it's testing for both. But you can use the other assessments to cross-reference and understand where that limitation is really coming from. And I already hit that. Shoulder adduction is testing for upper rib cage expansion, anterior to posterior T2 through 4, for very similar reasons as why the abduction is both anterior and posterior, just different muscle fibers. So 30 degrees is the goal here. Now this one is, I want to incorporate that because that's where the shoulder needs to stay. If the shoulder comes any higher than that, it's going to be very easy for them to roll on the table. So you want to start there, keep that shoulder pinned, and then go in. I would call that about 30-ish degrees. So that's probably pretty good. Now, my right side does not look like that because if we think about the right BC, we know that the right side is going to be more limited in this measurement. So that is what I would call a cheat. If you see them roll like that, that is not a genuine measurement. And you can see that that is the difference right there. Let's go back a little bit. That's a genuine measurement. That is not a genuine measurement. I can send you guys a YouTube playlist of these videos if you want to go over them. Just let me know if you'd like that. Something else you might see, oh yeah, they might go too high or too low here. I don't know why they would do that, but anything's possible. So if discomfort is felt, you might see that too. You might hear, ooh, I get a little pinching in my shoulder, a little impingement. Obviously that would be indicative of when you should stop the test. That should say T2 through 4. Shoulder flexion. So this is what I call the squat of the upper body. So what we can do here is you can measure this upright, but I've gotten away from that more recently because people cheat so easily. So I really like to lay them down. You can do this also with a straight palm like this. That would be perfectly acceptable. But what we're ultimately looking for here is about 170-ish degrees. I find, again, it's like that, getting that less 10 degrees. Is it really worth it? I don't think so. But you want to keep that elbow perfectly in line, perfectly in line. You see how much easier I can get my arm to go overhead if I turn out my elbow? Watch right here. That is not a genuine measurement. because I have now just basically pushed my humerus into internal rotation in order to do that. I've basically just done this. Here, drive it out like this, instead of getting that actual nice full scapulohumeral rhythm, which is what we're looking for here. So this is testing basically full posterior expansion. Where you get stuck is going to be a huge indication as to where they're lacking expansion. So other things to look out for. Yeah, it's just me turning out my arm more. You see how I keep my ribs down here? If I didn't keep my ribs down like that, then you know that I'm cheating. That is not a genuine measurement. And that's another way you can look at it from a top-down view too. Cheating. So if they get stuck at 0 to 60-ish degrees, actually that should say 90. I'm gonna change that. Yeah, that's correct. All right, if they get stuck at 0 to 90, then you know that they have compression in the lower rib cage below the scapula. That would be T8 and below. So that would be an indication this person's probably in anterior pelvic tilt. I made a post the other day about if you arch your back really hard, it's really hard for you to get your shoulder overhead because you're compressing your mid and lower back, which is preventing your scapula from going into that upward rotation. If you get stuck at 90 to 120, you know that you have a compression at T5 through 7, mostly posteriorly, but also anteriorly as well. Beyond 120, that limitation is going to come from the upper rib cage. So you can cross-reference this with all those other assessments, and then you're going to get the right result pretty much every time, because you know that you have multiple, you basically have redundancy, which I think is very important. If we only go off of one thing, it can be misleading sometimes. But see what's going on with shoulder flexion, see what's going on with all these other things. And they're all really easy to get done one after the other because they're in the same spot. Little fun fact, the side that is better in shoulder flexion, that is the side we are likely rotated to within our thorax. So for example, let's take the left AIC, right BC pattern. Okay, I'm sitting on my right hip, and then I counter rotate my trunk this way. So rotated to within our pelvis. So then I'm going to have better shoulder flexion on my right side than I am my left side. I'm also going to have better ER and also abduction on the right side than I will on my left side. So that can be a little indication that you can use to determine where their body is rotated to. So I'm rotated to the right because I have this underlying pattern. I haven't compensated a ton on top of it. So I know that I am rotating to the right. I'm going to have better measurements of expansion in my thorax on the right. Okay, now that we have all those done, let's talk about some thorax presentations for narrows. This is what you would expect to see, assuming no secondary compensations are present. That's the key word. Their internal rotation is going to be less than 70 degrees. External should be full. Shoulder flexion should be 160 or more. Their shoulder abduction should be full, and their shoulder adduction will be limited. Sometimes you might see their abduction limited as well, but usually they don't have an issue with that as much. Within their pelvis, they're going to have a full squat. They should have a full squat. Toe touch will be knees or mid shin because they can't nutate as well. Supine knee to chest is going to be 120 degrees. And then straight leg raise is going to be probably less, around 50, maybe less, maybe more, depending on what their hamstrings are doing. But because they lack internal rotation and nutation, it's going to be hard for them to access those mechanics. And then their obers, they're going to fail because they can't couple extension IR and adduction together. Within a wide ISA thorax, what you would expect to see is full HG IR. I've never seen that really, but this is what you would expect to see because everyone has compensated. I've never worked with one person that hasn't compensated. HGER should be less than 90 degrees. Shoulder flexion should be 100 to 120. Abduction is going to be limited, so is adduction. That is also going to be limited. So if you see this in a wide, you know that they're probably relatively primary. Within their pelvis, you will see a parallel squat because they can't recounternutate. Toe touch is going to be mid-shin because they can't recounternutate. Supine knee to chest is going to be less than about 110 degrees. Their straight leg raise is probably going to be 70. And their obers, they should be able to pass it on both sides. Should. Now, let's talk about the left AIC pattern. So given all of these assessments we've just taken, what would you expect to see with someone who is in a left AIC or has these underlying left AIC tendencies? It's all relative depending on where we're starting from. So if we're narrow, we're probably going to have way better active knee to chest, hip flexion than straight leg raises. So even regardless with that, you would still expect to see them have a better supine knee to chest on their left side than their right side because the left side can access expansion better. Straight leg raise will be better on the right because the right can access compression mechanics better. Obers will be better on the right because the right can access compression mechanics better. It should always sort of look like this. Even if someone's heavily compensated, you often see, like, let's say they've got a 45-degree straight leg raise. Oftentimes you'll see, a 45 on the right, 40 on the left, things like that. Within the right BC, we talked about this last week, but just to review it, the internal rotation on the left is going to be better than the right. The external rotation on the right is going to be better on the left. So basically all these compressive things are going to be better on the left and all the expansion things are going to be better on the right. Here are some optional tests you can do. You don't have to do these, but I like to do these if I'm kind of on the fence with someone, if I want a little bit more information, but you don't have to do these. You can do femoral rotation. So you can do this in a prone position, a supine position, whatever you want. Really, you're just looking for 45 degrees of ER, 40-ish degrees of IR. You can use knee extension as a test. You can just have them sit and extend their knee. If they can get full knee extension at 180 degrees, you know that they can get femoral IR with relative tibial ER because of that screw home mechanism. So if you want to know if they can get that femoral IR, this is a good test to do it. Knee flexion is the opposite of knee extension. So you're going to get femoral ER, tibial IR. They should be able to get to 130 degrees with this. If they cannot, then you know that they're missing that femoral ER. I'm a wide, so it's hard for me to do that. So I am basically sitting here at 107 degrees. All right. So after we do all this, it's very, very important to test and retest. With every single client I have, I offer a little business thing just that I do. I offer a free consultation for anyone that wants to work with me because what I want them to do is I want them to see the before and after, and I want to see the before and after. So I will assess them and then I will pick a technique I feel like will help them. And then I'll do it with them and then I'll retest them. If it got dramatically better, then I know that we're on the right track and now I know what we need to do. If it didn't get a lot better, then I know one of two things is happening. Either I didn't coach it well enough or it wasn't the right exercise. So those are the only two options. So from that, we can deduce that we probably need a different intervention or our assessment wasn't accurate. And then we can kind of backtrack from there. But also what people do is when they see you improve their range of motion with 5 breaths of something, you've got them because no one else can do that. And now you guys will have this skill set where you can just have someone walk in, improve the range of motion, and then boom, they'll buy in because you can make a tangible change in a very short amount of time, which people love to see. It's a good selling tactic too. So online assessments, if you guys work with anyone online, this is kind of the order I go in. I will have them start standing. I'll do the toe touch, I'll do the squat, I'll do the shoulder flexion, and then they're on the ground and you can just bang out all these. I usually do it in this order. And ISA, you might be asking, well, where do I take their ISA? Sometimes I don't, just because it's really hard and people really struggle to do it. If you have a very, very short amount of time, Let's say you're working in a team sport environment where you don't have, you know, the 7-8 minutes it would take to assess each athlete or individual thoroughly. I would recommend you do this. Take them into a toe touch and then immediately have them drop into a squat after that. And then do the active knee to chest and then do the shoulder flexion. Because remember, you can use shoulder flexion to see where their limitations at. And then you can just kind of go from there. Is it perfect? Absolutely not, but it's going to give you a pretty good indication of where they're at. And I also have an assessment sheet. If you guys want to use that, I will provide that in the materials. I use this with all my clients. I find it's pretty intuitive, pretty simple. It's nothing too sexy, but if you guys want that, you're free to use it. Okay, let's go through a full assessment together. So it's really important that I would highly recommend you guys do this because everyone I know that's really good at this has started on themselves. They were one time a patient. So, or, you know, a client for someone else who does these things. So let's go through this whole thing together. Turn on your camera if you are able. And that'll also help me kind of see what's going on with you guys as well. So I will share my screen again with each of these assessments, and then we will go through them. And I'll kind of walk you guys through some things. We can't do OBERS, obviously, but we can do, we'll start with the general order I would use. So let's start with a body weight squat. If you can turn your camera on, please do. If not, no big deal. So toes straight ahead, feet hip width apart. And then what I want you to do is slowly descend into the hole and then hold that bottom position for as long as you're comfortable with. Get familiar with it. Jonathan's got a really, really good squat. Ryan's got a good squat. Tomer's looking like he's got a good squat, making sure that your toes are straight ahead. Wow, we got a lot of narrows in here. Raul looks like me. Paul is looking like he's got a good squat. Tyler's got a good squat. We got a lot of good squatters in here. Nice. So it looks like a lot of us passed that squat assessment. Write this down if you want. In fact, I'd probably recommend that you do, because next week, now that you have your full assessment, we're going to see where you've compensated. So write down what your assessment is and we'll kind of take it from there. Okay. Now that we've done the squat, let's go into the toe touch. So toes straight ahead, feet hip width apart. Keep your knees mostly straight. You can bend them like 5 degrees if you really want to, and then try and touch your toes. Amy looks like she got her head on the floor. Raul is looking good. Eduardo's looking good. Everyone's looking good, it looks like. We got some compensators in here, which is what you usually see. So pay attention now. If you can, look at yourself as you do this. Look at what your thorax is doing. So for example, let's see if I can see anyone doing it. So Amy's really close to the floor because I think she's compressing her thorax. She's really good at doing that, which is not atypical of a narrow who does what she does. She needs to be flexible, so that's normal. Let's see. If you guys look, so Corey, if you don't mind me using you as an example, you have a little bit of that tent occurring. So everyone check out Corey. You guys can kind of see he has that little, can you walk forward just a little bit, Corey? See the whole, yeah, go ahead. Yeah. Perfect. You can see that he's got a little bit of that tent going on there. You guys see that? Flat, curve, flat. So he's using his rectus. All right. So record that assessment. Now let's go on to shoulder flexion. Let's lay on the ground. You can put your feet up against a wall. Or you can have your knees bent in a hook line position. Doesn't really matter. If I have someone for the first time, I'm probably gonna have them put their feet up against a wall. All right, now you can either straighten your arms out perfectly and supinate your hands, or you can just use your elbow. Go one at a time first, making sure regardless of what you're using, that your elbow stays straight ahead and you're not turning out your hand and you're not turning out your elbow. Make sure that your back stays flat on the on the floor. So Ryan, I don't know if you can feel it, but you're starting to turn out your elbow. Do you know what, you see what I'm saying with that? Yeah. Raul, you're doing a good job of staying really accurate with it. I can see that you want to turn out your elbows there and you recognize that. Eduardo, your palms are starting to, yep, there we go. Nice. So this is really a good measurement of shoulder flexion. We can stand up. Like I sometimes have some people stand up, just do a quick 1-2, but it's really easy for people to shove their head forward, and it's really easy for people to arch their back. Compare one side to the other. Is your left side better than your right, or is your right side better than your left? Your right side probably should be better than your left. If your left side is better than your right, then you have compensated. Looking good. Okay. Now, since we're on the floor, let's do that active knee to chest. So let's get our foot up against a wall and then make sure that down leg hamstring stays pinned and pull that leg back until you will feel either a pinch in the front of your hip, you will feel like that knee wants to abduct, or you will feel like you need to roll your pelvis. Make sure everything's staying in line. Get a good measurement of where you're at. Yeah, I'm seeing a lot of people getting stuck at 90, 100 degrees. That's very normal. Looking nice, looking nice. Amy's looks good. Eduardo's doing a good job. Everyone's doing a good job here. All right, record these, compare each side, and then let's move on to the straight leg raise. So you can just stay in the same exact spot if you want to, and then keep your leg perfectly straight. The second you feel like that knee needs to bend or your other leg comes off the floor to any degree whatsoever, you know that you have ended your test. We're looking for about 70 degrees here. If you get less than 45, then you know that you got that compression going on within your deep hip external rotators. Let's see if we have anyone like that. So Eduardo's kind of on the fence. It looks like you're getting past 45 degrees just by a hair. So I would say, Eduardo, you probably are a narrow who is lacking internal rotation. Would you say so? Looking good, looking good. All right, compare each side to each other, and then let's move on from there. I'll give you guys a second to write some stuff down. This will be really important for next week when we talk about what to expect with different compensations.
With the active straight leg test, can you have like would an over recruitment of rectus to hold everything down be a compensatory pattern, or is that going to be kind of normal?
You know, that's a good point. Usually because people are doing this test with their shirt on, and it's hard for me to determine if that's the case. I don't think that's a huge problem I look out for, but I think it could be possible for sure. Because if you think about what the spine needs to do at the end range is recounternutate. So if they're going to use a rectus to crunch and squeeze it down to get that job done, I could see that happening. You know what I mean, Tyler, when I say that?
Yeah, just say that last part one more time. The yeah, okay, nice.
So if this needs to happen at the end, right? They need to get this back to allow for that to happen. Okay, so if they were to crunch their abs and push their back into the floor with their six pack, then that would allow them to get more range of motion.
Okay, now what if they're like, okay, when I was doing it, I noticed my rectus was quite active, but I was still maintaining the curve of the spine. Like I wasn't smashing into the floor.
I wouldn't be worried at all.
Okay, cool. Yeah. All right. And then
do we have another question?
Yeah, I have one.
Go ahead, Fleming.
So I do, if I'm doing assessment on a client, if they complain about low back problems or hamstrings or whatever in the pelvic region, I do a test kind of like put them in this position, and then I do IR and ER. Mm-hmm. And if I find that there's a kind of excessive ER and IR, you haven't mentioned that assessment. I'm just curious because I use that in my assessment. What is that a tell of? If you could put a few words on that.
Yeah, so you're saying they have a ton of ER and limited IR in that supine femoral rotation test.
They have a ton of ER and IR. Yes, both of them.
Oh,
And they are actually complaining about hamstring or low back, especially hamstring, actually, from the track and field athletes I have.
I think that person is heavily eccentrically oriented. So
tell me about it.
Yeah. So PRI has this thing called pathological pelvis. And I used to use that term in this program. I don't anymore because I'm not sure that it's the best representation of what is actually going on, but I think it's accurate to probably what's going on here. So what PRI says happens is if you're really externally rotated, then you basically stretch out the integrity of your iliofemoral and pubofemoral ligaments, which attach down here within the femur and basically anchor your femur into your pelvis. So if those and the tissues of this surrounding area are eccentrically oriented and they're heavily eccentrically oriented, then you basically have a femur that's not centrated within the acetabulum. And then what you have is an individual that's super loose. So what you'll see with these people is they have a palms to floor toe touch because they just bypass any relative motion in their pelvis and they just do that. You're going to see them, if you do anything like a Thomas test ever, I've gotten away from that test too, but they're just going to drop really easily. These people are going to squat very easily because they're bypassing all relative motion and they're just using their eccentric orientation. So Fleming, I think that's what they're doing in that case.
Yeah, that makes sense because the person is very much eccentric oriented in the training, and it is like a cooked spaghetti kind of.
Yeah.
And I have a lot of those athletes, so I guess also that in their training they're using a lot of kind of like tilted forward pelvis, and that's why they are trying to strengthen the hamstring in an eccentric manner instead of getting the tucked pelvis and then training after from there. Sorry.
Most definitely. And I would say with those people, tempo squats are going to be really important. Anything with tempo is going to be really important for those individuals.
Thanks.
Yeah. Any other questions before we keep going?
In the toe touch,
yeah.
Raul, in the toe touch, if you see like difference in the curve of the spine, is something you write down and to look for compression in different areas?
Yeah, I'm looking at the spine when they do it for sure, and I am taking note of it. So within the toe touch box, I will write down compression. Well, I mean, that's the language I use. You guys can use whatever language you want, but I would say like compression at mid thorax, expansion at, lower thorax, things like that. That's like what I say, but I do take note of it because I think it's very important. As people get better, their toe touch thorax presentation should improve. It should look more neutral.
And when you see like lumbar spine, like we haven't talked much about it. So what does it mean?
If you see a heavy rounding of the lumbar spine.
Not rounding, like straight low back.
Yeah, here, let me show you real quick. If you see that, I think that would be like this red line right here. I think this would be an indication that they're compressing the crap out of their rib cage and they're able to do that. And they're also really eccentric within their hamstrings. So they're, again, bypassing the relative motion and they're going straight through orientation in order to get there.
So, I meant more like you have a straight,
more like me.
You have a straight low back and then you are gaining the range of motion through other parts of the spine.
This is a rectus strategy, I think, what I'm doing right here. This is that rectus abdominis compressing, pulling me down to get there. So I probably don't, in my squat, this lines up with what my squat does. I hinge my squat, so I don't recounternutate. So I'm not recounternutating here either. I'm just using my rectus to compress my thorax to end that toe touch. Does that make sense?
Yeah, it's the same as I do. So.
Any other questions?
But I put past the toe touch, but
yeah.
Still I'm really bad at squatting.
I saw you do your squat, yeah, and also it reminds me a lot of myself, yeah. So I think you are probably using a rectus strategy to complete your toe touch. That would be my best guess.
Okay.
I have a quick question, Connor.
Yes.
So It's just a little one. With the toe touch, like how straight are we looking for the legs to be? Because I can't figure out if I'm bending my legs too much or not.
I say, with most people, I say keep them straight, but also you want to, I like to say just have a very, very slight bend. Now look out if they bend more than that.
Okay.
So if you see them, because at the same time, if you have them like really locked out, then they could just be more predisposed to using their thorax instead of their pelvis. That's why I say slightly unlock.
Right. So like here would be okay if you have like a little bit of a bend.
Yeah, I would
But
say.
if you're like here or you're here, it's probably too much.
Right.
Okay. Not like a deadlift or anything really straighter than that, probably.
Mhm. Yeah, like 5 degrees of bend.
Yeah. Cool. Thanks.
Wouldn't the if a person did do it like and they put their palms on the floor with their legs completely locked out, wouldn't that just tell you they have an eccentric orientation to their hamstrings and they're probably bypassing the pelvic mechanics?
For sure.
Okay.
All right, let's do shoulder internal rotation. I think that's where we picked up. Yeah, let's go IR on the floor. You don't have to put your feet against anything. Just make sure your shoulder is outside, your elbows directly outside the line of your shoulder. You're keeping your posterior shoulder pinned on the floor, and then you're going down from there. Yeah, this is the one where people start to see. Yeah. And then going to ER too. I've seen a lot of people with full ER and a lot of people with very limited IR. It's very, very common. I like how you guys are being genuine about your measurements though. Notice how you want to cheat the test sometimes, but you can't if you're doing it right. So I don't think anyone here has full IR. Nice. Oh, Amy might. All right, let's now do a deduction since we're on the floor. Keep that posterior shoulder pin and then go in. Notice how many degrees you have there. Make sure you're not rolling. All right, let's now do a abduction. You can go write down those other three though. You guys probably want to find a bed or a couch or a bench, anything you can lay off of.
With the test we just did, I feel like when you say posterior part of the shoulder, it can't be here because as soon as I lift, this part comes off. So am I just like kind of like lateral border of the scapula or even like the
yeah, I point to the exact location on the video if you guys
okay.
So it's, yeah, it is sort of like that. It is sort of like that. Yeah. Yeah. Upper lateral border back there.
Like that.
Yeah. I think that looks good, Tyler. All right. And then after your abduction, you're all set. So hopefully that was helpful. Make sure you have that for next week. And then we can use that as a way to sort of see where you're at. And then we can have some pretty cool case studies. I would say in your small groups this week, when you meet, assess each other and kind of like go in the details. Like, okay, this person had a 30-degree straight leg raise. What does that mean? Oh my God, 120-degree straight leg raise. What does that mean? So go through those things. And I hope you guys enjoy it. And let me know if you have any questions. Anything else on you guys' mind?
Yeah, I have one quick question.
Yeah.
Well, I'm lying. I probably have more than one quick question, but that's what I'll tell you for now. Okay, wrist extension during shoulder ER. Okay, I notice that all the time. Now, sometimes people, you said like they just want to pass the test, but other times I feel like they have no clue that they're doing it. Because even when I say like, hey, don't extend your wrist after I explain what that is, they go and they're like, okay, and then just it just happens. So where would like if you've confirmed they're not just doing it to cheat but they're doing it, it's like they don't even know they're doing it. Where else would that show up and why would that need to be addressed? I've been addressing it, but I'm kind of like, why? It
doesn't really matter, honestly.
Really?
It's minimal. I don't really care if they do that much because you just look at the forearm and then you got your answer. You know, like I can crank it back or I can keep it neutral. Regardless, it's not doing anything for me really. So I just make sure as like you're not measuring your fingertips. That's why I kept that in there, because if you measure this, then it's obviously you're getting an extra 10 whatever degrees just by using your fingers. So make sure you're measuring the forearm. That's why it's important.
Just tell them to stay off the motorcycles.
I have a question. I have a quick question about shoulder abduction. So it basically you're doing this, but you're on the floor.
Right, and you're not rolling. So it looks like you're rolling there, Amy. So feel that border, that upper lateral border of your scap, and then keep that pinned on there and then going. That looks better. I think. I can't really tell. Does that make more sense to you though?
It does. Thank you.
Of course.
What I was gonna say is like sometimes like when I'm assessing myself, I don't know if it's like just basic like ligament laxity or something that's actually structurally like not like wrong, but it's because of a structural issue.
On which test?
No, just like on like the tests in general, because like when on the like the straight leg test, like my leg will just like go up past like 90, but I don't feel any kind of like tilting. Like I don't feel any kind of I don't know if it's just like ligament laxity or if it's just, I mean, I guess I just have to like test and retest.
I think it's just you're eccentric. You're a yoga teacher, and you also have been doing that for a very long time. So, I mean, I'll ask you, do you have a lot of pain? Do you have a lot of like nagging injuries or anything? Then I don't see what the problem is really. I think if that's what your job is and you need to demonstrate movements, then I think it's perfectly acceptable for you to have a huge straight leg raise. I think it's just you're eccentric within your hamstrings and those tissues and you're bypassing relative motion. But if you're not really experiencing any problems and that's your job, I think it's okay.
Right.
For the for the squat and the toe touch, should we be doing them barefoot?
I actually don't really ever, I don't make that distinction really. I think most people, because I do online, most people are in their house with their shoes off. So that's an interesting question. And I can't really answer if having shoes on or off has ever made a difference, because it's just not something I've paid attention to.
Just saying, you know, if you've got an elevated heel for the squat, you would be able to squat much better. But meaning, sorry, you may cheat the test because you've got an elevated heel.
Exactly. That's something to look out for. Yeah, and that's honestly just my bias. I do online stuff, so people have their shoes off when they work with me. But yeah, that is definitely something to look out for.
Yeah, you see in every CrossFit gym in the world, people just trying to get their depth by wearing the lifters.
Oh yeah. Raul.
Yeah, Connor, if you are not assessing the ISA or you have someone you are not sure of where is she or he, how do you know where you need to go, or like the hierarchy of things that you need to work on?
So if I've got someone's ISA and I have these assessment results, how am I using the ISA with that?
Yeah, like you said, like what we want is like the thing that we are biased to, but if we don't know which things are we biased, how do we know to what should be working?
Right. Yes. So this is what, okay. So let's just get into some week 6 stuff. So when we address someone, we want to go for external rotation expansion first, because people compress themselves to find an exhalation strategy. That's what people are doing. They're trying to exhale. So they keep compressing. So we need to expand them first. Then after that, we need to get them back to what they should be as, a typical ISA. So the reason why we need to know what someone's original biases are is because that's going to help us choose the positions we want to put people in. With narrows, we want them to be in prone positions because that facilitates anterior expansion. When we have wides, we want to put them in supine or sideline positions because that's posterior expansion, or anterior and posterior expansion in sideline. So I want someone to get back to what a normal narrow quote unquote should look like, or what a normal wide quote unquote should look like. Then once we get to that, they're probably also in a normal sort of left AIC pattern. So you got to unwind the layers of compensation, and then you get to where they should be. And then you can fill in the gaps after that.
But if you don't know if you are wide or if you don't know if the client is wide or narrow,
then yes, then what I do when someone is, let's say 100-degree ISA, I'm going to look at their body and I'm going to make my best guess. And honestly, a lot of the times it doesn't even matter because you're going after expansion first anyway. So by getting someone in a position where it facilitates that expansion, it's probably going to be fine, but it's not the end of the world if you don't know someone's ISA. It's really not.
okay, thank you.
But I would encourage you down the line, because what you want to do is get a dynamic infrasternal angle. So it should be able to expand and compress, and it should change a little bit as you progress through the program. It's not going to go from like wide to narrow, for example, but it will probably alter itself a little bit. And then once you get to the end, you're like, okay, this is where you're at. So now you can adjust from there.
Connor, I have a specific question that's just relative to me. So, I have this weird pain going on in it's like left SI area, sort of left glute. And it actually gets worse if I'm sitting, my hips are at 90 and my knees are at 90. It'll get worse if I look straight down, and it'll also get worse if I extend my left knee forward. And the weirdest part is that squats, like regular back squats, don't hurt it. And a concentric deadlift won't hurt it, but an eccentric deadlift will. And this has been going on for a while, and it gets better and worse certain days. But I'm just wondering, without knowing anything else, what you thought of that.
Yeah, are you wide?
Yeah.
So I'm also wide, so I relate to what you're saying with pretty much a lot of that. So I think what's going on is we're really good at posterior compression, really good at it. So for me, back squats feel better than front squats up to a certain extent, because I'm really good at compressing myself and getting that job done. But if I do too much volume of back squats, I run into problems very quickly because it's too much of one thing. So I think that's why that concentric strategy is what you're really good at. So that's why it doesn't hurt you, because you pattern yourself how to not do that necessarily. But when you go eccentric, when you have to access more expansion mechanics, I think you start to compensate because that's your weakness. And then in terms of the extension on your left leg, it could just be that, within that left AIC pattern, you don't have as much IR on that side. So you could just be having to compensate to find that knee extension. And when you go down here, that's flexion. So again, flexion, eccentric, kind of hand in hand. So what you're doing there is basically just getting into what you're not good at. So I think we would need to expand you. We need to give you some expansion mechanics. And I think that would help.
Sorry,
Did I answer your question?
Sorry, you froze like the last side. What was the last thing you said after expansion mechanics?
Oh, that was pretty much it. Yeah, just expansion would be good for you. And yeah, from there, and just maybe some eccentric work in the weight room would also be good.
Gotcha. Yeah, I generally have a tough time, sort of scaling something like let's say like a left adductor pullback up, because if I lay on the floor and I do the adductor pullback, it'll feel good for a few minutes, but then the next day it's like kind of just sort of back to where it was. So introducing load definitely helps me. Something like a split squat, maybe, where I'm doing like an ipsilateral load when my right leg is forward, that generally makes it feel better, weirdly. I find that left abs also sort of help the issue.
Oh yeah.
But I just don't want to, keep making it worse and stuff.
Yeah, I think using those loads is important for you because you don't have a high enough stimulus with that left adductor pullback. Like, you're a big, strong guy, so it's going to be hard for that little sideline drill to do a lot to you. Those drills are really helpful for people that are detrained or have a very low level of fitness. But once you get up to the range that you're at, you need to stimulate yourself with real load, because that's what got you into where you are. So to get yourself out of it, you're going to need to use load. And I think those split squat variations would be massively helpful for you.
Gotcha. All right. Thank you.
Anything else? I think we had a couple of questions in the text. Oh, I think Kevin left, but his question was, with the upper body assessments, is there a big difference in what you see if client has legs straight or knees bent? Not really, as long as they're not arching their back. I like to do knees bent a lot with that stuff just because that hook lying position facilitates that counter nutation. So it's gonna be harder for them to cheat on that. Raul asked, do you allow hinging on the toe touch? I don't really want them to hinge because they can turn into a deadlift, but they should have a posterior translation. And James asks, for shoulder flexion, is the angle of the humerus we're looking for 170 degrees? That's correct. Yes. 160, 170 is usually like pretty acceptable. 170 is probably better. All right. Anything else?
Sorry, that question for Raul's one. Distinction between hinging and just toe touching.
This would be a hinge. You see that? And then this would be a toe touch. You see how much my hips go back relative to that? A hinge is this, and it's also going to involve more knee bend. Whereas I should still posteriorly translate, but it's more of a forward full than anything else.
Yeah, okay, cool.
So a toe touch is basically like a shitty hinge.
Yeah, that's really what it is.
Gotcha.
Connor, my question went because I know some people that work with this kind of stuff, and they try to make the toe touch as less hingy as possible to see how his pelvis move more than just giving some room posteriorly shifting.
Yeah, I think that could have value. The reason why I don't do that is because I want to see what they do, what their natural movement is. And I want to see what's available to them when they're just going through a given movement. Because I think if you put a lot of constraints on it, you can maybe, get very myopic on one thing, which could be of value. But for me, I just want to see what their body naturally wants to do.
Okay.
Hey, Connor.
What's up?
If somebody's posteriorly compressed and can't pass the toe touch, would you want to clear that up before doing something like RDLs or deadlifts?
Yeah, I think if you're getting stuck at like knee, meaning that you can't nutate and you can't really get into that internal rotation position, I wouldn't have you hinge. I think that's a really good question. I'm glad you asked that because yeah, that would be an indication I wouldn't want to hinge that person. Or if I did hinge them, it would be with a ton of constraints, like, band around the waist, pulling them back kind of thing, toes elevated, just patterning it without much load.
And how far down would you consider passing it? Like, how good of a toe touch would you consider a pass or fail?
Literally just fingertips to toes.
So if they, like I was doing deadlifts today, I could only get to like mid shin. You think that's a bad idea?
I don't know. Like, you're a trainer, I'm assuming. So I think you have the ability to hinge, but it might not be the best thing for you because you can't nutate. So I think I would probably want you to access those nutation mechanics before you hinged heavy, but you could probably pattern yourself into a good hinge with like a, for example, elevated kettlebell or barbell deadlift with a ball between your knees, something like that, help open up that pelvic outlet. That's where I would probably start you.
Cool. Thank you.
One thing, Connor, I think I didn't catch this part, but when you're doing the abduction test, how much is your scapula just like moving? You don't want it to, or stable. You don't want it to retract, right?
Not necessarily. I mean, through the nature of that movement, the scap's going to come back, right? It's going to go into a degree of external rotation. But if they're like pulling it back before the test start, they're going to get stuck.
Okay. And that wouldn't limit like posterior expansion because the scapula is coming back. Is that blocking off or not really?
No, I think it is. And technically in that position, yes. But I mean, not like it matters in that position because you're assessing what it's doing. But if you did want to compress someone posteriorly, like have a narrow, for example, get anterior expansion, that's why snatch grip deadlifts, that's why really wide grip back squats can be of value to people.
Okay, cool, thanks.
These are all great questions. Anything else?
Quick one, just not necessarily linked to what, well, kind of linked to what we're talking about. If you're doing a bent over row, so that's a reach. So say it's you're doing it from the floor, bilateral. It's a reach at 90 degrees. So where I'm getting confused is at where the compression. So when you pull that up towards your chest, is that because you're concentric in the rear, so you're getting expansion in the front, or is it the opposite? I'm getting confused with that movement.
If you're inhaling as you pull, yes. But you would probably want to exhale in that position as you pull. That's like a Pendlay row kind of thing.
Yeah.
So yeah, like me and Ben are probably really good at these because we can compress, we can get here, and just as wide as we can get after it. But a narrow is really going to struggle with that. But for example, if I wanted to somehow turn that into, you know, a corrective, quote unquote, you could have them inhales, they come up, or you could just have them exhales, they come up, pause at the top and inhale. But that might be really hard for some people because they're going to want to kick on their low back. So I would probably use some light dumbbells or something like that. But it just as long as they're feeling hamstring tension, generally speaking, that's going to help them shut off their low back. So if they feel the hamstring tension like they should before they pull in a deadlift or something like that, then generally that's an indication their low back won't kick on. But yes, to answer your question, if you can get back here, inhale in that position, you're also prone, anterior expansion all day.
Cool.
Mm-hmm.
Could you maybe like flip that around for a wide and give them like a chest support and inhale like when you're fully reached, so the air just goes straight back?
I would say even in that chest supported position, if you're facing down, it's still going to be anterior expansion.
Okay, gotcha.
But you could be on there is a world where you could be like more of an incline here, and then the reach is naturally lower, and then you get more posterior.
Gotcha.
Connor, I think someone mentioned it before that about doing the rotation of the hips too as another assessment, as well as we do the shoulders, because if we do all the assessments that you gave us, I have found people that are good in all of them, like narrow people or girls that move a lot better, but when I do the specific rotation of the hips, then that is when I find what are they lacking.
Mm-hmm. Yeah. So in those cases, like this is probably one of those really eccentric people. If they pass everything and there's still issues, then yes. But sometimes you run into an instance when, you're talking about rotation like this kind of stuff.
Yeah.
Yeah. So because that could be a real case where they just literally impinge on the rim one way or another. So for example, if you're narrow and then you're going 90 degrees of hip flexion, then that could be problematic because you don't have a lot of IR. So you start here and that's going to affect your testing outcomes.
Okay.
So do you have maybe a specific case with someone like this and they had a ton of ER or IR in this position?
They were limited in both things. I have 2 or 3 cases where they are more or less good at most of the tests, but they lack a lot of, or they did before I'm working with them.
Mm-hmm.
I don't know.
Yeah. So for example, if they're here, they're narrow and they're here, usually what you see with these people is they're going to have a hard time further externally rotating in this position because they're already there and they've pretty much run out of room, but they can access internal rotation a lot in that position because A, they're at 90 degrees of hip flexion, and B, they just have more room to move through it, whereas they're kind of already sitting at end range of ER in that position. So that's why you would see a limitation in ER potentially there for narrows. But in terms of IR, it could just be a lot of things, like it's very easy for people to bypass, again, using orientation as opposed to relative motion. I would imagine in this case, this individual is, using a similar strategy for all those tests that they pass. But once you get them here, it's more reflective of what they can actually access, because this is more position based and it's harder to cheat with muscles.
Mm-hmm. Okay.
Anything else? I'm here for any questions you guys have. I'm not going anywhere. Unless there are no questions.
I have a question, or like something. Lately, a lot of like my like fellow yoga teachers who have been teaching as long as myself have been asking me. They're like, "Oh, are you experiencing like this and this and this injury, like in your shoulders or like in your sacrum?" And I tell them, I said, "No, I've never experienced a yoga injury," and I think it's like what's happening is that when you're not like complementing, like stretching out like your muscles and ligaments and not countering it with like progressive overload, that's going to shift your, like, is it going to shift your skeletal position in such a way that like your pelvis does become pathological, or you become more narrow or more in one other like disposition?
When you are already in like an orientation of yourself and you add load?
Well, you're not adding load.
You're
like
not.
you keep on reinforcing that stretching, that laxity.
Yes. So if you just keep making yourself really eccentric and you're not really ever giving yourself compression, then yeah, there are cases where you can just, push yourself along that path even more and more. But then you're going to pass all the tests, and we're back to a similar situation we were talking about with Raul. So I don't know if you're going to make yourself more narrow per se, but I think you're going to approach the end game compensatory strategies much quicker, because you're going to be seeking a compressive strategy, which will make you want to compensate more and more. So I think you would just eventually wind up in the tertiary layer of compensation.
No, this is really helpful because in a way it's helping me like gain like more clients from like this particular population. And yeah, like the thing is that when I'd rather, when you have so much mobility, then the ability to orient yourself in a compressive kind of way is like the body doesn't know how to do that, and to like retrain the body to be compressive is really challenging. So
it is, yeah. And I think you hit a good point there. And I think people are very much like, getting someone to expand and decompress is the hard part, but nah, I think it's getting someone to compress and getting them out of, crazy mobility is the hard part, which is a sentiment I've heard in the past. Like it's easier to give someone range of motion than take it away. So I think using this as an example, I think, yeah, giving like, especially people who are crazy eccentric, giving them the ability to hold and compress and do it correctly without compensating is quite challenging, but there are lots of ways that we'll talk about we can do that.
Thank you so much.
Mm-hmm.
Super helpful.
Anything else? Going once, going twice. Okay. Well, guys, thank you for coming. Yes, I hope you have a great rest of your Monday. I hope you have a great rest of your week. I'm going to be rescheduling the review session because obviously Thanksgiving is Thursday. So I'll put a straw poll in the chat right after this. See you guys later. Thank you for coming. I appreciate you guys staying until the end.
Thanks, Connor.
See you, Ben.